for anyone to disclose a conflict of interest. Do I have any disclosures? None. Seeing none, we'll move to the mission statement. Okay. Dr. Nettles, would you be kind enough to read our mission statement?
Absolutely. NGH mission statement: to improve the health and wellness of Nashville by providing equitable access to coordinated patient-centered care, supporting tomorrow's caregivers, and translating science into clinical practice.
Thank you. Next thing I'd like to do before public comment is, just for a second, is thank Dr. Hudson. In my absence last meeting, she was chairing the Finance Committee meeting on with my absence, and I just appreciate, I understand the time and diligence it takes to run the meeting, so I really appreciate you doing that. Thank you.
Of course, my pleasure.
I'll be out for the rest of the year, so just thought I'd cover that real quick. Next item on the agenda is public comment.
There are none.
No, okay. The next item up is the approval of the minutes. Are there any comments or amendments to the minutes?
Madam Chair, I'd just like to make a comment and it's actually suggesting going forward that the minutes reflect a couple of things. One, who was not in attendance, and then second, I'd like to have more detail in terms of what was moved and seconded and things of that nature, because a lot of work is being done, and I just wanted to detail reflection of this work. So while I'm not making any corrections now, I'd just like to have this consideration.
Thank you. Thank you for the feedback, and I'm sure Ms. Lester's taking some notes, and we can easily adjust to that. Oh, I'm sorry, Sharon. Sorry, I jumped ahead of myself on the other meeting. So thank you, Sharon, for doing that for us.
I so move that we accept the minutes.
Okay, is there a second?
Second.
Okay, any discussion? All in favor?
Aye.
Aye. Motion passes. First contract up is KJ Trauma Consulting. Dr. Elders.
Can I start by just saying the two contracts that are listed under Dr. Elders are two of the contracts that need to come back before the board that were listed as recommendations in the internal audit to bring them into compliance. And I'm actually going to have Bill Campbell come up and join at the podium. He is our trauma program manager, and he will assist with the KJ Trauma Consulting. I'll give a little history, but he can talk more about the ins and outs and why we need it. And then also the Sonic Insights, Asia Cooper Colquitt, who is our Senior Director of Ambulatory Services, will come up and talk about that. I will say both of these contracts have already been in play. One is which is the KJ Trauma Consulting, which is a amendment of the current contract. You can come on up. The amendment of the current contract, and so I'll turn it over to Bill at this time. Welcome, Bill.
Good afternoon, board members. Bill Campbell, I'm the trauma program manager here at Nashville General Hospital. KJ Consulting, they manage our trauma registry. We are a level 3 state designated trauma center. By such, we have to maintain a trauma registry. And when I started here in 2021, we looked at two companies to do that, KJ and I'm not 100% on the other name. I believe it was Q-Centrix. KJ Consulting was more cost effective, and when I reached out to the references, they got a much better reference from talking to the other folks that use them. They manage our data collection, the abstraction, the coding of the injuries, the report writing, and then our submissions to the state. We're required to submit data to the state quarterly, and once we get that data in, we get funds back from the state for that. So.
Thank you, Bill. You're good. I also want to mention that this contract was executed in 2021 with 1-year amendments through 2023, and the previous amendment expired June 15th of 2023. However, it did have a clause to where you could extend it for 1 more year. In doing this amendment, which will be in effect from the date of approval through next December 31st of 2026. If we went and renegotiated a whole new set, we would have had different pricing. So this pricing is based on hours worked. And in the contract summary form, we included the numbers and what we have used with this company in the last 4 years. And so you see it varies based on the worked hours and what we're going through at that time. 2022 and 2023 was our, I want to say one was our provisional period and the next one was our confirmation year. And so now it's dwindled down just a little bit, but this is an amendment for your approval. Any questions on KJ Trauma Consulting?
Is there a motion to approve the KJ Trauma Consulting contract?
So moved.
Second.
Any discussion? All in favor?
Aye.
Aye. Motion passes. Thank you. Next up is the Sonic Insights Medical Corp.
Hello. Hello, how are you? I was like, that's not Asia, but okay. Oh, that's awesome. That's awesome. But this is also one that from the internal audit we needed to bring back before the board. And what the reasoning for this coming before the board or should have come before the board was based on the terms versus the cost. And so they'll present that. This contract right now is being used in our GI clinic.
I'm Julie. I am manager of the GI clinic and endoscopy. Better? All right. I'm Julie. I'm the manager of the endoscopy center and also the GI clinics. And what we're bringing before you is called a Velicur scan, and it is utilized to scan the liver to look for fibrosis in the liver and prevent our patients from having to have liver biopsies to be able to prove liver disease. The Velicur scan is kind of like an ultrasound, basically is the easiest way to put it. And we can do those in office. It takes about 20 minutes. And there's no anything, and they go home afterwards. And we get a 3D image within about 10 minutes. The initial price was $45,000. It is on a 3-year contract with no renewal. And it expires in August of this year.
Actually, so the contract term was August 17th of 2023, and it ends August 17th of 2026.
26.
So again, we are just bringing this contract before the board for approval and to be in compliance with the recommendations of the internal audit.
Yeah. Dr. Martin?
Madam Chair, Dr. Elders and I discussed the presentation of these contracts and how it is important, particularly on clinical equipment, to have one of the users or somebody from that area to explain to us what the equipment does, and rather than somebody from the leadership team, somebody that actually is there using it, and and it would have been useful in particular when this was purchased. Why are we purchasing this? And so hopefully going forward we can do that. Thank you for.
I have a question just really out of curiosity. I see that there's a proposed 780 scans, and that figure was used to kind of justify or estimate the anticipated revenue over the course of 3 years. Is this based on patients that typically you've had to do the liver biopsies on? Okay. Just curious. Thank you.
I had a quick question in terms of the internal audit, just to make sure I remember this correctly. So these two contracts that one we just passed and the one here, remind me, why were these not presented in the past?
I'm not sure why they weren't presented. Now, I will tell you they did meet the requirement for the bylaws, which is why they were flagged by the auditor. And so I can't go, the leader of that area at the time is now gone. Now, I believe for the KJ Trauma Consulting one, we started doing level 3 and based on cost, and it was by, billed by hour. So it's really billed by hour. If you really look deep into the original contract, it says $120 an hour. So I think there was some, perhaps misjudgment about it, whether it should go or shouldn't go. It should go because of the term.
Okay. Thank you for that. And then last, just more of a comment, not a question, but I appreciate the fact that there's an estimation of the 3-year revenue, because that helps us understand, what we are paying for. Is it more qualitative with regard to care, which is absolutely a necessity, but also I appreciate, as a math person, I like the quantitative action. So I appreciate, here's what we pay and here's all the money that we can make off this. So just appreciate y'all going to that level of detail in this contract. Any further comments or questions?
Can
Yes,
I make
ma'am.
one more
Of
comment?
course,
So
Dr.
with
Albers.
these two, what we have to do is provide the link of where they were approved at both board meetings, and that'll satisfy this recommendation. There were only 3 contracts in the internal audit that were flagged that we did not terminate. All others have been termed, and we've provided proof of termination. The other contract was a contingency physician recruitment firm, and we gave them termination. And that will conclude for our contract piece in the audit fulfilled. Thank you.
I do have one question, which is somewhat unrelated. With the pending the imminent dates of these, I assume that you all are looking at new possibilities and even more cutting edge and whatever, refer. Okay. Yeah, I'm just going to ask that all the time. So just know that and that's my need to make sure that I'm doing my due diligence to be the reminder. Thank you.
Any further discussion? If not, I'll entertain a motion to approve.
Motion.
Is there a second?
Second.
All right. Any further discussion? If not, all in favor? Aye. Motion passes. Next up is the triads. Dr. Brown.
Good afternoon, Madam Chair and board members. TriHas contract was a contract for medical waste disposal. That contract came before the board in February. We didn't have the other 2 bids that went with that contract, so we went back and got the 2 bids, other 2 bids for that contract, and so now we're bringing it back. The current contract that we're on is a month-to-month contract, and so we're seeking board approval for us to engage in this contract for hazardous waste.
Can you just briefly, you mentioned the 2 other bids. Can you just briefly mention your conversation around those and experience?
Okay, so the reason why we're one is there's a $7,000 some increase, and the reason for that increase is because the increase in disposal of medical waste going forward. So based on what we've disposed of from the last company compared to what they would, it's a little bit higher cost going forward with that company. And then the services that are provided, these are going to be a little bit more detailed. They're going to, so we're sort of bringing several things together, like shredded, which is our paper waste the documents that we throw away that have to be shredded for HIPAA compliance and stuff. That's also included in this contract as well. So the other ones were a little separated, and we had different companies doing different things. But with this company, it's a holistic approach.
So it's hazardous plus paper
Yes,
plus
ma'am.
other?
Yes, ma'am.
So it would take care of the institution?
Yes, ma'am.
Okay.
And so the other 2 companies that you got bids on segregated this, or you would have to obtain another contract? Is that
Yes.
what you mean by holistic?
Yes.
Okay. And so the increased cost is specific to the volume of
Waste that we
medical
produce.
waste and services.
Yes.
Comparatively. Okay. So the other 2 companies did not do a more comprehensive, and I'm guessing are more expensive, or?
Right. There were like limited services that we were
Okay.
getting from there.
Right, thank you for the clarification.
Quick question. Will there be some additional cost savings then, since this one is more holistic and is bundling? It
Well,
sounds like is it taking the place of
It
other
depends
vendors?
on us as an organization. The more we're mindful of what we throw in those bins, like the ICRA bins and the different bins, the more we would save, right? But if we just pitch things into waste that require us to send it out for hazardous disposal, then costs increase because we pay by the poundage.
Okay, thank you.
All right, any further conversation or questions for Dr. Brown? Seeing none, I'll entertain a motion to approve the TRIAS contract.
So moved.
Is there a second? Okay, any further discussion? Not all in favor?
Aye.
Aye, motion passes. Okay,
Next would be BedWatch. This is a company that allows us to track our patients as they're being discharged throughout the system and allows the environmental services staff to know that a bed is empty. We thought we were going to get this with the product with our Cerner implementation, but that didn't come to fruition. And so we need this in order for us not to have such a manual process to get our patients discharged. So this tracks those patients to make sure that we get them out in a timely manner and that we get the rooms cleaned.
Quick question. So I see that there is a little bit of a price difference. So what was in place last year? What's currently in place? I know you're saying it's a more manual, but there's a price for something that took place last year.
We had this company previous. We were under contract with them for about 3 or 4 years. We had BedWatch, but then when we implemented Cerner, we let the contract expire thinking that it would be inclusive into the Cerner project. And then we found out that it wasn't, so then we had to bring this company back.
Thank you for that clarification.
You're welcome.
And are there other companies as well, maybe a couple others that have been examined or explored?
Yes, there are several companies that provide that service.
did you guys go to other vendors to obtain pricing for this?
I believe she did, Madam Chair.
Who, Lindsay Tubbs?
Yes, ma'am.
Thank you for clarifying what I was trying to ask.
I thought that was also noted on this, which I appreciate, this contract summary information page, by the way. It's grand and very detailed compared to what we've had in the past, so I appreciate that. Where is that noted? Just so I'll know. I don't see that right off the top of my head.
I don't have that one in front of me.
All right, I can ask somebody after this, but I think that is something that would be helpful to have if it's not on here, that the other contract, any other vendors' names and associated costs, or specifically, another summary comment of why we specifically decided to go with the one that's being proposed. So I think that would be helpful too. Another question with regard to Cerner. Is this something that we can add on with Cerner? And if so, why would we not use that kind of add-on or plug-in comparative to BedWatch? And if not, in your opinion, why do we think we could do it and then now can't do it?
Madam Chair, I'm going to ask Ms. Thomas to come up to explain that.
Okay.
to you.
And I'm just saying, if there's a way to leverage the cost, if we're already, if it's a plug-in, it may just take time or what we need to do. So thank you.
Madam Chair, Cerner does have a bed watch product, which we did implement. However, it was not nearly as efficient as the system that we had before. So the original intent was to replace our existing bed watch program with the Cerner product, but once it was live, it was not sufficient. It just did not have all of the things that we were used to having, and it put us back into a very manual process. So it really impacted our productivity. So we wanted to go back to the original product that we had been using for several years because the productivity was much better under that product than with Cerner.
Well, I thoroughly appreciate the pivot because that really was what I was looking for, because I anticipated that was the issue, that something did not go particularly as efficient as you thought, and you had to go back to what you already knew, and that was the easiest thing to do. But concurrently now that you're looking at other vendors or other types of, I guess, implementation.
Yes. And I think one of the factors that we had with BedWatch that we wouldn't have with other vendors is we had an existing interface in place. And so that would also impact the cost that we would have to create an interface for another vendor. So that would kind of skew it would kind of skew what the costs were. So the cost would be more with another vendor because we'd have to consider the interface cost as well. So that puts BedWatch, our existing vendor, at an advantage.
So again, thank you for the pivot and the clarification, because I think it helps us understand what is necessary and what's needed.
I have one more quick question. So the bed watch that's integrated within Cerner, was that an additional cost? And so now it's a service we're not using?
So the bed watch was included as an overall cost, and when we did not, as we're not continuing to use it, we got credits for it.
Okay, that's where I was going. Hopefully we can get some money back. Okay, great, thank you.
Okay, there's no further questions. I will entertain a motion to approve the BedWatch contract. Is there a second?
Second.
Any further discussion? Seeing none, all in favor?
Aye.
Aye, motion passes. Thank you for the extra explanation. Next contract is Compliance Line, LLC, DBA Ethico.
Good afternoon, Madam Chair. My name is Chrissy Lewis, Chief Compliance Officer. I'm here to respectfully request the board's approval of the amendment for 1980 for the additional, the ability to do additional exclusion checks as is mandated by regulatory mandated. Health and Human Services require that hospital entities conduct vendor and provider and employee exclusion checks. Under the Social Security Act, it states that if you have an entity that is doing business with an individual or a business that has been identified on the exclusion check, that you will be subject to civil money penalties, which could range between $10,000 per incident, as well as a clawback for all of the services. And ultimately, you could be placed on the exclusion list yourself. In this process, with this amendment, this gives us 2,000 more, which helps us to look at all of our providers, which is our nurses, which is our physicians, as well as all of our vendors, which is a little over 450. So that will give us the coverage that we need, and it will give us the room to expand as we have more providers and more vendors that we would need to check. This is done on a monthly basis, and it is brought before the board, even though the amount is $19.80. It is it is an amendment to the first contract, which was for 5 years, and it had the total amount of $7,370.19. So it makes the total contract now $9,270.19. This was also done in an RFP. There were 3 others that we were considered. This was the most economical and giving us the greatest number of searches that we were able to do. So not only were we are able to do the Office of Inspector General search, we are able to do the system for award management, the U.S. Treasury blocked persons, as well as the U.S. Treasury sanctions check as well. So we want to make sure that we are accurate and thorough in following the regulations. For this reason, I respectfully request that the board approve the amendment for the additional numbers of individuals and vendors that we could check on a monthly basis.
Awesome summary. You gave us risk, benefits, costs, bids. Thank you. It was very thorough. I appreciate that.
Thank you. My pleasure.
All right. So no other discussion points. I'll entertain a motion to approve.
So moved.
Is there a second? Second. All right. Any further discussion? Not all in favor?
Aye.
Aye. Motion passes. Thank you. I did have one quick question. Sorry, Ms. Thomas. I had one quick question. Hey, Melanie. One random quick question on your bed watch. You mentioned this covers our beds that we have. Just out of curiosity, does the cost structure go up if, as we continue to grow and bring more people into the hospital? I'm just curious about the cost contract.
That, I don't know that. I don't have the answer to that
sorry.
question.
Dr. Brown.
No, ma'am. It's attached to the actual beds that we have. So it'd be like 5, 6, 7 in the floors that we currently have. So as we bring more patients in, it wouldn't increase the cost to that contract.
Okay, just curious. Okay, thank you. All right, that's it for the contracts. We'll move on to the next item, which is the fiscal year 26 budget update. And this is after many of you know and or have seen Dr. Blackledge on the Metro Council YouTube channel. So you're famous.
Thank you, Madam Chair.
Well, we'll
might
get
I
autographs afterwards.
Might I add a thank you on behalf of Dr. Elders as well, and tertiary, but not necessarily third. A thank you on behalf of the staff, team members here in Nashville General that was present in the room on that day last Thursday, May 22nd. I'll cover about seven items. So we presented last Thursday at our budget hearing. Our initial request was for $66 million, and mind you, the initial request went in on February of 2025. We were modified approved for $60.7 million. We made no request for additional funding during our budget hearing. We did cover about 7 different items, and I'll share those with you from a high level, and let me know if there are questions. Dr. Elders actually started us out and began to talk about the leadership structure and the changes that had occurred over time. So she addressed that with the committee that was present. Second, we spoke a lot about our programs and what we do. It was a nice slide that had many of our logos present and really was an overarching, kind of like Nashville General Hospital as the umbrella with 9 different programs listed out and sorted on that one slide. Then we went into a little bit of detail about what these programs mean to the community and to our Nashvillians, those that we are here to serve, and keeping in line and supporting our mission, the health and wellness of those individuals that live within our communities. So we talked about those programs. Thirdly, we talked about where our patients live. And that was, actually there was an interest from council members who wanted a little bit more detail. And so we do have some homework. We owe a report to those council members for patients of ours that live and reside within their districts. That was 3. On the 4th piece, we talked a little bit about the last 60 days and what things looked like for us over the last 60 days. So we had changes probably around the end of middle March. And I'll just point out 3 of those items. We talked about the PSA, the Professional Services Agreement between Meharry and Nashville General Hospital. the current state at that particular time. We talked about the Metro audit findings. We wanted to make sure that we got those items out up front and communicated the current situation, and we're prepared to answer any questions. Thirdly, we talked about the cost containment strategies. Many of you know we've focused on 2 items, reduction and elimination. You know, what is there, obviously with our budget numbers where they are, wanted to take a look at that holistically and make some changes. So elimination and reduction. The 5th thing that we spoke about was what does the future look like? What does that look like for Nashville General Hospital? And shared that with within our hearing time. And that was engaging KPMG, looking at workforce optimization, and then talking about our growth initiatives and what that means to the organization. I want to slow down and talk about the last one that we really shared before we got into questions. That slide was titled New Beginnings. And Dr. Elders will probably talk about this later. I don't want to share too much, but 2 things I want to point out is we were really clear about enhancing transparency, making financial pivots, and collaboration with all stakeholders. And the last piece was having a dedicated, empowered, celebrated workforce. That piece is highly important to this organization. The way that we get work done and achieve our targets and take care of the patients that we serve every day is through the people that are here to do that for us. So we wanted to talk about new beginnings. And I'll close right there. The last part of that, we had several questions. We answered those questions. We have a to-do list. Kathy Poole, who's probably, no, she's not behind me, but Kathy Poole took a detailed Q&A type listing for us. So we have a little homework to do. And that's it for us. So we were approved for $60.7 million. Let me know if you have questions.
How do you feel about that number? You know, it's almost $5.3 million less than what we wanted.
Yes.
I know that we've talked about ways to kind of burn that at both ends between cutting cost and growing revenues. And I know that you guys have a plan for that, and you've shared that with, I think, many of us, but do you think you can get to 60.7?
Yes, that's definitely our intent. We believe that we can get to 60.7. It is not easy. It is not an easy task, given the culture. I think we talked probably 3 board meetings back about the culture, the accountability, and economics. I mean, that hasn't changed over this past 90 days, right? It's more important than ever. So there are hard decisions. There are tough calls. Most important is we do have a plan. And in that plan, we must execute that part of it.
Please go ahead.
I will just add that this leadership team has really worked really hard to assess the organization and look at places, and it's been painful. We've had, some painful conversations. But to your question, can we get to 60.7? We can. It's going to take some hard work, and we're not going to make everybody happy in doing so. But one, it's a culture shift for our organization, and we are going to have to put some skin in the game and work and develop processes to make us more efficient.
Thank you. And did you want to make any comments or around where we are? I think that there's been some kickoff meetings with KPMG, and also maybe mention just some kind of proactive meetings / conversations we've been having with Director of Finance, and how you feel like those conversations have been going, those meetings, and even trying to find some 4% money, et cetera. So I'd just like to let you guys talk a little bit about all the work that is being done behind the scenes as well.
Right, so happy to talk a little bit about that, Madam Chairperson. I want to point out that you guys may have it'll say there's a packet in front of you that says NGH Board Meeting Payer Mix, Fueling the Mission, KPMG Update. The KPMG update, I'll go ahead, that's the slide that I want to speak to if you want to go ahead and spend some time getting to that page. That's okay. I'm happy to go over it, to cover it.
We can
Now
wait.
while I'm here.
I didn't see the KPMG on there, so we're good. We can wait.
Okay.
It's all fine. Any further comments about the Metro Council budget hearing? Okay. All right. Great job there, and thank you for representing us so successfully. Financial statements, Dr. Blackledge.
Thank you. We'll get started on that one, Keith will.
So my name is Keith Moran. I'm the controller. I'm not Miss Blackledge, but I kind of look like her, so we'll do good. So I'll go over April's financial statements, and it's almost end of May, so we hadn't got those done yet, so we're close. So our patient volumes for the month of April, we had inpatient admissions decline from 232 in March to 221 in April. Our observation visits totaled 211 for the month. It exceeded our budget of 174 and was greater than the previous year's 187. Our patient days totaled 833. We were slightly below budget of 868 with an average length of stay of 3.8. Our case mix and ER volume is as follows. So our case mix index for the hospital declined from 1.28 to 1.21, which means indicating a lower acuity of discharges. Our emergency room visits decreased to 2,155 from 2,252 in March. Our surgery procedures pretty much remained a little bit flat. They increased from 27 to 32, but our budget was 27 also. Our outpatient surgery climbed up to 115 from the previous month of 100, surpassed the budget of 87. Of course, cath lab, we still don't have a physician, so it's still in process, so there were no procedures in the cath lab. Our interventional radiology cases fell to 18, down from 28 from the previous month. Our deliveries totaled 37 for the month, up from 32 in March. Our clinic volumes was 4,511, which was down from March of 4,645. Our year-to-date visit volume is 44,482 versus 35,236. So we're up, which is great. Our income statement, our total revenues were $25.3 million, which was 10% below budget. Our inpatient revenue year-to-date is 6.7% below budget, with most of that is due to the cath lab not having a physician, so that's $4.1 million. Our outpatient revenue is basically the same. It dropped 13% below budget due to the cath lab interventional radiology shortfalls. But our net patient revenue totaled $5.27 million, coming to just $97,000 below budget. Our net patient revenue percentage was 20.8%, compared to a budget of 19.1%. Any questions so far about the information? Okay. Our other revenue fell 18.5%, but that was really due to we had a Medicare cost report settlement that we owed money back, $683,000. That was from the 22 cost report. We also in the future will have the same type of thing on our 23 cost report, which will be about $850,000 that we'll owe back for that cost report. We haven't officially got the bill yet, but it's in the mail. Our staffing expenses were 5.6% million, which was $674,000 above budget. Our total staffing costs, which includes all the salaries, wages, and benefits, was $7.8 million, which was $620,000 above budget. Contract labor costs were up from the previous month to $742,000, which was a $473,000 increase, but remained $334,000 below budget. Lease and utilities is over budget $259,000 to several unbudgeted leases, Metro Center, various medical and IT equipment. Overall, the total expenses were $12 million, which was $609,000 below budget. Our net loss for the month was $1.1 million, and year to date we're at $19.9 million below under budget. Any questions concerning the income statements?
Why were there unbudgeted items in Metro Center for medical and IT?
Well, it's not in Metro. It's just overall IT.
Okay.
Yeah, it's not specific to Metro.
Okay. So
It's hospital wide.
any comments as to why those were not in our budget?
Was not here to know why, but we can find out why and let you know. I don't know of any particular reason off the top of my head, except there was some leases that were signed that happened during the year related to clinics that were not budgeted at the time. And probably it's got to be the same thing related to medical equipment.
I'll just say, if I may, that I don't believe as we've added services in the past, that we've looked at those costs that needed to be included in those services and adjusted the budget. And I think we'll get to a better place as we overhaul the financial infrastructure.
Okay. Yeah, so just making sure that those are accounted for going forward, if that's something, a service or a good that we're going to keep. So I think that's making, and obviously you guys have set it up now, but there's a process by which everything comes to the budget.
Yes, that is true. Everything comes to
No
be
surprises.
approved by the budget, and this won't happen again this year.
Question. So with our collaboration with KPMG, is this something that they would take on? I can't remember the length of that relationship, but is that something they can work through our shortfall of the budget that we were anticipating or hopeful to receive versus what we have, and how we're seeing that there are things that are unbudgeted? I'm just wondering if within that collaboration, is that something they can assist us with going through and kind of fine combing and reallocating budgets or allocating funds to create an updated budget?
Happy to respond to that question. Absolutely. So just we can get into a little bit more of it, but absolutely, yes.
And
I have a question. It sounds very elementary, but whenever I hear we have to pay something back, it sends a red flag, and will you explain to me what that means?
yeah, and we had two cost reports, one in 2022, Medicare cost reports, and in each one of those cost reports, we were supposed to include the IME reimbursement and filling out the cost reports. And the person who is no longer with us had filled out those cost reports and left those numbers out. And so when Medicare caught that, we had to pay the money back. So when we filed the cost report, we didn't claim that we had gotten that funds. So we got paid for it. So when they caught it on the audit, they are requesting a reimbursement back.
And were there any fines or penalties associated with that?
Oh, no.
Okay.
It's just the heartbreak of having to pay that money back.
Well, that's what I was getting ready to say. We never want to have to resubmit funds or pay money back to the Medicare program. I mean, that's number one. And then two, the method and manner in which it occurred with us is the dollars were actually taken back from our remittance advice. So you have people, and such. I see faith in the room and others who work hard to collect the dollars than to have them taken back. So they're looking for their check, right? And so when they don't get the check, that's a bigger issue.
And let you know that in the 24 cost report we just filed, we put in a process to, so this would not happen again. So this was one particular, I'm not sure why it was left out, but it was accidental, I'm sure.
Well, thank you for always collecting the lessons learned. You all are doing an exceptional job with that, so.
Thank you. Other items, next month, when receiving the $9 million for Metro, that will be coming into income for the month of May, so that'll be changing our year-to-date funds. And then also that's pretty much it for the income statement.
Any comments, Keith, on the inpatient, outpatient reductions on the revenue side? It looks like about 1.2 million, 1.5 million actual versus budgeted.
That has to do with the, as far as inpatient, outpatient, that has to do with the cath lab. Is that what you're referring to?
Yeah, and I put because of the cath lab in my notes, but I just, does anybody want to provide an update on that?
Do not have, do we have another up, there's not a, on the cath lab.
We do not have an interventional cardiologist. So I know our CMO, Dr. Bullock, is looking at how do we engage other organizations to find some resources for that. We don't have the volume to hire one full-time interventional, which is really truly the problem. Now, we do have a interventional radiologist that uses the cath lab for cases, and that's that minimal volume that you see there on that line. But as far as a cardiologist to do caths, interventional cardiologist to pick up that volume, we are exploring opportunities with other organizations.
Okay. We can go over the cash flow statement and the balance sheet. Okay. All right. So on the balance sheet, really the major changes that's been since the year end has just been capitalizing of leases, new leases, and that our accounts payable has increased by about $4 million. And our accrued liabilities has decreased $4 million, which is a net of no large increase. So that means what we did was we shifted some manual accruals to our AP. The other big change on this page is the net property, plant, and equipment, and that has to do with capitalization of the Cerner project. So it went from 46 million at the end of last year to 70 million currently. As far as cash flow statement, this will show you that we currently have at this moment, we have at the time of this statement, we have $5.5 million in the bank. The cash flow for the month, we had a negative $610,000 compared to a year of minus $8,582,000. And so our cash flow usage is declining, so that's good. So for the average is going down. So right now we have $5.3 million we just got from the city, our supplemental, and then we got one more, it's around 1.5 million. It's some odd numbers, but we're about to request that, and that will be our last supplement for the year. And we also used the $9 million we got, 3 of it we kept for payroll reserves, and 6 we put towards accounts payable in the month of May. Any questions? Okay. And so the pie chart, I don't know if you got a chance to look at it. I always got to show it off because it shows the percentage of our expenses where they fall. And you'll notice that in the month, we had less expenses as far as non-salary. We had less expenses, so that's why that's skewed for salaries and benefits compared to budget. And then year-to-date, it's pretty much right on. That's all I have.
All right. Thank you, Keith. Next item up is on, let's see. It's our pay mix. We need a motion to approve the financial statements. So do I have any further questions, or do I entertain a motion to approve our financial report for April 2025?
They are previously for information only as they continue.
Are we going to continue to do information only? Yes, okay. All right. We'll continue to, until we get through our KPMG audit, it is the recommendation to, okay, all right.
That's what we agreed to previously.
All right, next up is payer mix.
All right, thank you, Madam Chair. Let's talk a little bit about Nashville General Hospital payer mix and a review over the most recent 3 years. And I think we'll get to a slide piece there to show. And you guys have to keep me honest. I took my watch off so it doesn't buzz, but keep me honest on time. So from the payer mix standpoint, our intent was to look at our insured population and our uninsured so that we could understand basically where our sources of income come from, who comes to us, whether they have insurance or not. And oftentimes some of the populations we're going to look at, these patients may not have insurance when they enter our door, but we have programs that we essentially screen our patient population for to tie them to a program for reimbursement. So here you have our payer mix over the 3-year trend. Our board chair, Dr. Martin, did make a request to look at over the most recent 3 years. The most important takeaway for this slide is really looking at our patients that are insured versus our uninsured, and then by that service year, and also looking at it whether they were physically in the bed or whether we actually saw them in one of our outpatient clinics. So going from left to right, I'll just share that the trend really is the inpatient insured population year over year is going up. So we've moved the needle from 67% to 71.6%. Our inpatients that are uninsured, that has gone down from 32 to 28%. When we talk a little bit about our outpatients, from an outpatient standpoint, we're steadily seeing that our insured population is increasing, and that's what we would want. You want your insured increasing on the inpatient and the outpatient side year over year. On the outpatient side, the number of uninsured patients that we are seeing is decreasing year over year. And again, some of this is our ability to communicate just in time with those patients, get them signed up for other state programs and whatever they may be eligible for, communicate that with them, have team members to follow them as needed, if needed, through some of our teams to make sure we collect the information necessary. And feel free to ask any questions. I'll move to the next slide where we get into a little bit more detail and look at, okay, the ones that have insurance, tell me who their insurance is with. So when we think about our inpatient versus our outpatient, again, by the service year, I'm not going to call out each one, but a couple of things I do want to share. We already have noted that we are seeing an increase in patients that are insured. So where are we seeing that? The line item that has the most growth is probably in our commercial line item. So we want to make sure that we point that out. We're seeing more commercial patients year over year. I will talk about the bottom two, which is Davidson County inmates, which we are not reimbursed for, and we're not reimbursed for the uninsured population. When we think about our revenue, there were a couple of questions earlier from the revenue perspective. I will go ahead and share that for the inpatient, which is on the left side of this chart, our revenue, this population makes up about 28% of our revenue that comes in. The right side of the chart deals with our outpatients, those that we see at clinics that come for a quick test or something, a procedure. We have about 72% of that is driving our revenue. A couple of things that relates to our efforts is people and individuals within the community having access to group health insurance. You guys know we came off COVID, so you're seeing a little bit of that trend through our numbers too. The unemployment trend, what we're doing from a marketing standpoint, and then our growth plan, which one was, we had the Metro clinic, so we talk about clinic acquisitions. I'll move to the next slide, and this slide is probably the first year where we have the true picture with the Metro clinic included, because I believe it was February of last year when we brought them on. So this is clearly a full picture, not broken out or not segmented by inpatient and outpatient, but a holistic picture of what we have and who we treat. And I want to pull your eyes to the bottom of the chart where it says Davidson County inmates at 4.05% of our total patient population, uninsured at 28.8%. And if we combine that, that's about 32.8%. I want you to hold that thought. So when we think about, we are chartered through our city of Nashville, Davidson County, we hold a charter. We know that about 32.8% of our patients are not reimbursed at this point in time in our fiscal year to date. So we flip the page and we bring our budget conversation into our patient population conversation. We flip this page, we should see a pie chart. I'll start with the red bracket. This bracket has 60.7, and it makes up about 38.2 of our income. So when we think about our income source and our subsidy from Metro and how we utilize that income source, I'm just tying those two together so that we have that understanding. And there's a delta, probably about a 5.7 or some % difference. But when we're asked about, hey, this 60.7, what does that look like in comparison? I'm just bringing it to the table that when we look at this and then we look at our payer mix and those that are insured and uninsured and understand our charter, it kind of comes full circle for us. And so the total pie that we have as it relates to income is about $158.8 million. Now, these dollars, we are allotted, but we have to utilize these dollars in a way that we're being good financial stewards, and we've spoken a little bit about that, driving accountability. I want to pause and talk a little bit about our relationship with Metro Finance. I was asked that question earlier. So for those in the room, I want to make sure that we share, you guys know, we meet with Metro Finance monthly. It's a more broader meeting, including some other stakeholders. But we want to be transparent. We want to collaborate. We want to explore opportunities where we might have some financial synergies that haven't been tapped into at this point in time in our relationship. We also have weekly meetings, and there are different individuals in the meeting depending on the subject matters. There are also 4% pools, funding pools, that we have not, let me just say, consistently participated in. And so we want to be consistent, we want to be transparent, we want to be talking about the needs of the organization and the benefits of the organization to the community, because it's not just coming to the hospital to see a provider. We do so much more than that. We take care of the whole person. And in order to do that, this 158.8 serves as our income to support those programs. I'll talk a little bit about the net patient revenue just so there's a little bit of clarity. These are the dollars that we actually collect. So the 67.4 is representative of 42%, but those are dollars collected based on the insurance payer mix, that pool of population that you viewed earlier. So I'm just tying this out for everybody. And then if we drop down On the other revenue piece, that's about $8 million. I want to tie this back to a couple of things that we heard earlier. Keith brought up the Medicare cost report, those dollars. We also have pharmacy. We make some dollars over our pharmacy piece of it. Dr. Brown, sitting behind me, opened a pharmacy location off-site from campus in our Metro clinic area. So that kind of serves as some of our other income from a retail standpoint. We have the School of Health Professions, so just sharing where that income resides and comes from. And then we have additional state funding, which we've talked about all year long, right? So we don't have the $10 million that was in there from last year, but we have what we have previously received in prior years. So just to kind of share that piece of it. Then you have our DISH funds from a Medicaid standpoint at 1.7. And that's really making sure that because we treat a larger population of uninsured patients, we're able to say, okay, this fund, we can have dollars out of this fund because of our patient population. And that's where this piece comes in at. So when we look at this from a whole picture, the 158.8, we take this into consideration, and we had a conversation prior to heading to our budget hearing, probably 2 weeks in advance of budget hearing. And based on everything that we know and the changes that we need to make within our organization, it would have been extremely difficult for us to ask for any additional funding beyond the 60.7. And so it's connecting that to a couple of other data points that we've just spoken about, like the patient population and other items. Any questions around that? And Madam Chair, I hope I answered your question about how we feel and about our relationship with Metro. And some of the items that we discussed, like the 4% fund, pool fund.
I personally think it's the most in-depth discussion we've had about where our money is derived, how it ties. I think, we hear a lot of high level, kind of we deserve. But I think this is really helpful in terms of specifically tying the subsidy to the patient population, but understanding that's only a third of the pie. The rest of that is coming from other revenues and obviously the growth of NGH, and more importantly, where we can go to as we continue to tell the story and NGH continues to grow the patient population. So I think this is very helpful. I feel like it is helps even people like me understand, who are not healthcare folks, understand at a very high level what's going on and what the opportunity set is. So thank you. That again, after almost 2 years or 3 years, whatever it is at this point, this is to me the best explanation I've had.
So that was answering our question. If we want to move to the KPMG, or if there are no other questions around that piece, you guys tell me on time. And I took my watch off, being honest.
Yep.
What time is it? It's time. I'm hearing it's time, so I can.
Yeah.
I'll follow your lead.
We don't want to hold everybody too late, so I think we'll. I know we're pushing into our full board meeting, so we're going to hold revenue to the next board meeting, and then I think Dr. Elders has an item as well on hold. So with that, if there are any further comments or any other discussion points, if not, I'll entertain a motion to adjourn.
So moved.
Second.
Thank